started. Welcome to Grand Rounds for September the 10th. We're continuing our Zoom method of doing rounds and plan to continue doing so at least until the end of December, and we have a schedule prepared. Rounds will be a combination of chairs rounds and locally rounds from either HHS or St. Joe's, and today's round is our first Chief Medical Resident Grand Rounds for the season. I'd ask you to keep your mic muted, and at the bottom of your screen you'll see there's a Q&A and a chat option. I'll try and keep an eye on the Q&A and chat as we go along. So today's round is being presented by Anthony, Tammy, and Victor. And whenever I read the bios of our medical residents, I'm incredibly impressed. Tammy has a PhD in biochemistry and did postdoc work in California and is a third-year resident. Victor has a Master of Applied Science in Biomedical Engineering, is interested in medical oncology, clinical trials, and therapeutics. And Anthony, equally impressive, holds a Master's of Science in Global Health and is interested in GIM and health service inequities. So these guys are very impressive young people, and I invite them to go ahead and get started.
So good morning, everyone. Today we'll be talking to you guys about goals of care, including some recent literature and the legislation surrounding its provision. Next slide. So we have no conflicts of interest to disclose, and there was no funding provided to us for this presentation. Next slide. So our agenda today, a brief case presentation, some background literature on the topic itself, recent evidence that was our motivator for pursuing this topic for rounds today, legislation from the CPSO and the CMPA, including advanced care planning in Ontario, and finally, key points and future directions. Next slide, please. So our case presentation, and this was a real case for me at some point in my career, 84-year-old male from retirement home admitted with pneumonia, presented with a DNRC form from the community. However, the physician ordered goals of care was left blank on admission. Post-admit day one, noted to have hypoxic respiratory failure. Code blue was called. The patient was admitted to ICU and was intubated. Family was unreachable. Post-admit day two, family presents to hospital with withdrawal of care. So where did we fall short in this scenario? The first goals of care expressed by the patient were discordant with the life-sustaining treatment offer. However, some healthcare providers may have felt that there may have been involvement or changing of the patient's preferences. The next may have been prognostic uncertainty of the healthcare provider, whether a resident doctor or other, admitting the patient to hospital with prognostic uncertainty. Perhaps they felt that there may have been a change in clinical scenario from what the patient would have considered when designating goals of care. And overall, I think is a lack of physician communication and documentation in this sort of case. Next slide, please. So before we begin, we thought it would be helpful to include some terminology that we commonly see. So advanced care planning is a discussion with possibility of recording patient preferences surrounding goals of care for those who may lose capacity or communication ability. This may, but not necessarily, involve choosing a substitute decision maker, but is not a replacement for consent, and consent is still required for all activities. An important distinction is that advanced care planning does not equal an advanced directive. On the other hand, advanced directive is explicit instructions to consent or withhold treatment in specific scenarios, and is often formally documented and usually includes appointing an SDM. And then finally, a healthcare directive is a legal document where a capable person appoints an individual to make medical decisions on their behalf. Next slide, please. So as a call to action, in 2015, a group of physicians published a review article in Canadian Family Physician highlighting a need for advanced care planning. Their conclusions were that half of Canadian adults have engaged in some form of end-of-life discussion with their families, but this was often much less frequent with healthcare providers. In the acute setting, documented medical orders correctly reflected patient preferences roughly only 1/3 of the time, and the majority of patients that were polled were interested in discussing goals of care with their physician, even while healthy. Most often, we do have goals of care discussions in the acute care setting. However, these physicians felt that it was most appropriate to be conducted in the primary care or outpatient setting. Next slide, please. So, in terms of some background literature on this topic that's been published over the last 10 to 15 years, we thought it would be helpful to highlight these 4 articles. The first was a retrospective review in New England Journal of Medicine, and then a bit of cognitive framework that was published in JGIM. Finally, one more study in JAMA, and then a systematic review published in 2014. Next slide, please. So the first study we've chosen to highlight is understanding treatment preferences in the seriously ill patient. The author's motivation for pursuing this study was because goals of care discussions are often focused on specific interventions, for example, CPR, intubation, vasopressors, while omitting treatment outcomes and their likelihood. This was a retrospective study with a questionnaire admitted to patients who were diagnosed with severe or advanced heart failure, COPD, and cancer. The caveat is they didn't necessarily provide qualifiers for what severe and advanced meant. Either way, the patients were provided with 2 questionnaires, one with treatment with known adverse outcome, and the second, a similar questionnaire, but different likelihoods of those adverse outcomes were provided to the patient. Next slide, please. So their conclusions were summarized in this figure here. A burden on the healthcare system generally means length of hospitalization, degree of testing, or invasive diagnostics. Perhaps obvious, but low burden on the healthcare system with a promise to return to current health. 98% of patients would want treatment. Then once stratified into high and low burden with severe or functional cognitive impairment, the results were different. So with high burden on the healthcare system, but a promise for returning to current health, and that's on the left-hand side of your screen, the majority of patients would still want treatment regardless of the burden placed on the healthcare system as a whole. Next, in the middle, with a low burden on the healthcare system, but severe functional impairment, the majority of patients would not want treatment. And then similarly on the right-hand side, low burden but severe cognitive impairment following intervention, the majority of patients would not want treatment. So the conclusion from this and the takeaway point, I think, is that advanced care planning should consider not only the patient's attitudes towards burden of treatment, but presenting the patient with likelihood of possible outcomes, which may assist in kind of clearly delineating the goals of care discussion. Next slide, please. Next, we thought it would be helpful to include some literature exploring the cognitive and psychosocial factors that go into decision-making surrounding goals of care. So generally, affective forecasting is the overarching psychosocial term that we can use to describe what patients are tapping into when making goals of care decisions. And this is an umbrella term. It's a bit multidimensional and involves envisioning future well-being. It is composed of 3 cognitive elements. The first is focalism, where an individual may tend to focus more on what will change rather than what will stay the same. Immune neglect, failure to envision how their coping skills will lessen their unhappiness with a certain outcome. And finally, failure to predict adaptation. So value shifts that occur with decision-making and as those decisions evolved. So I think this is more of a piece that we chose to highlight for the physician or healthcare provider to be aware of these cognitive factors that go into decision-making and may assist you in kind of exploring why or why not a patient is choosing a certain intervention. Next slide. Next, we chose to highlight a prospective study exploring failure to engage hospitalized elderly patients and their families in advanced care planning. This was a prospective study of exploring advanced care planning and concordance between preferences in care and correct documentation. This was a study performed at 12 acute care hospitals in Canada and exclusively highlighted elderly patients who the authors felt were at risk of dying within 6 months and their family members. Next slide, please. This is one figure from the article, which I think we all feel summarized the findings well. So you'll see two graphs here, one on the left and one on the right. On the left is patient preferences for care and documented goals of care. And similarly, on the right were family members' preferences. Each graph is given a scale from 1 to 5, where 1 is what we consider in our system to be full code. 2 is active medical management without critical care measures. 3 is comfort measures, or similar to a palliative care course in our system. 4 was a mix, and 5 was unsure. And globally across the scale, whether looking at patient or family member preferences, whether or not there was a high degree of expression of a certain goal of care. Overall, the documentation, which is the darker part of the bar graph, was not withheld in these 12 acute care hospitals in Canada. Next slide, please. And finally, a systematic review published in Palliative Medicine, exploring the effects of certain phrases of advanced care planning on end-of-life care. This included 113 studies and explored the effectiveness of different types of advanced care planning. And generally, articles were included if they explicitly focused on ACP, had some element of quantitative research, and include outcomes on the effective medical treatment on the last phase of life, including compliance with the patient's wish, what medical treatment and care was offered, hospitalization, length of stay, and an effect on quality of life and satisfaction with care. And these were articles between 2000 and 2012. Next slide, please. So, to be brief in what the systematic review showed us was that 3, first, do not resuscitate orders explicitly saying DNR on a chart, did reduce CPR and hospitalization, increased use of hospice care, but its association with other interventions, for example, nasogastric tube feeding, diagnostic invasive measures such as thoracentesis or paracentesis and other was unknown. Similarly, do not hospitalize orders, and maybe a bit more obvious, but reduced hospitalization and increased hospice care. Its association with invasive testing was relatively known because the patients were completely avoiding hospitalization in the first place. But I think the most important piece that we took away from this systematic review was that complex advanced care planning, meaning formal communication between the patient and healthcare team, whether that's a physician, nurse practitioner, or other, with completion of the advanced care directive, was most important to increase the frequency of out of hospital and out of ICU care and increase compliance with the patient's end of life wishes and satisfaction with care. Next slide, please. So some of the literature we've showed you thus far carries the following implications for decision-making. Communicating treatment outcomes and their likelihood is important, and perhaps a trial of treatment is important if depending upon the likelihood and burden on the patient and healthcare system. Understanding the patient's education and cognitive framework and cultural social norms around decision-making may assist healthcare providers. Engaging in end-of-life discussions in the outpatient setting or primary care setting may be most beneficial, and promoting these discussions earlier may encourage younger individuals to explore these issues and help with decision-making in their relatives and parents. And finally, open communication and documentation with the patients ensures adherence to goals of care. So if you feel comfortable, filling out the form with the patient at the bedside, allowing them to see what we see as the healthcare team, may close the gap between what the patient's expressing and what we're documenting. And then I'll hand it off to Victor, who will go through some recent evidence that we chose to highlight.
Thanks, Anthony. Right, this paper we chose was kind of the impetus for us to do this topic. This was a paper published earlier this year. It's an American paper, and the authors looked at, for patients with completed posts, so physician orders for life-sustaining treatment. For these patients near the end of life, how often is their inpatient care actually consistent with what is documented on the post? So we'll dive into the actual study more carefully, of course, but their conclusions was that among patients with completed posts, chronic life-limiting illness who were hospitalized within the last 6 months of their life, that treatment-limiting posts were significantly associated with lower rates of ICU admission compared to those with patients who had full treatment documented on their posts, which is what we would want and what we would expect. We would want reality to be reflected by what's documented in the post in an ideal world. However, they found that 38% of patients who had documented treatment limiting orders still ended up receiving intensive care. So there was potential discordance with what happened and what was documented in their post. So this study was a retrospective cohort study in a single healthcare system, specifically University of Washington Medicine, that consisted of 2 hospitals. They were both larger hospitals. And the patients that they looked at were those who had completed posts, who had a chronic illness, and who died between 2010 and 2017, and were hospitalized at UW within the last 6 months, within 6 months of their death. So chronic illness they defined as follows. So it's fairly broad: chronic lung disease, coronary artery disease, CHF, heart failure, peripheral vascular disease, chronic kidney disease, chronic liver disease, diabetes with end organ damage, dementia, and lastly, cancer with poor prognosis. So primary malignancies with poor prognosis, leukemia, or metastatic disease. They don't specify exactly what the severity of illness has to be. So it's a fairly broad spectrum of patients that they included. And in terms of patients with completed posts, they specified that the posts had to be completed prior to their last inpatient admission, and not during or at their last admission. So this is their post that they have in Washington. It's got some similar elements to what we have here, but there are some significant differences. I think the most important difference is that their post is statewide, and also that it's effective across all settings, including hospitals, until either replaced by new physician orders, or avoided by the patient themselves or their substitute decision maker. But in terms of similar elements, again, in section A here, for example, you can specify CPR or DNR or A&D. But for this particular study, they focused more on this section B here, medical interventions. They stratified their patients to, well, 3 categories as listed here. So patients who documented comfort measures only. So ICU level care would not be consistent with what this goal is. Limited additional interventions, so medical interventions, but without critical care. And then lastly, full treatment. And then for purposes of their study, when they did their analysis, they actually combined these 2 groups together because they share the commonality that patients who had both either comfort measures only or limited additional interventions should not receive intensive care if possible. And that leads us to the outcomes. So they looked at whether patients received intensive care during their last hospitalization of life. And they defined this as either being admitted to the ICU or receiving 4 of the following life-sustaining treatments. So either mechanical ventilation, vasoactive infusions, new dialysis starts, or CPR. And then again, as I mentioned earlier, they were also very interested in seeing what the rate of post-discordant care was. And they also wanted to see if there were certain factors about the patient that affected whether you were more likely to receive discordant care versus less likely to receive discordant care. So figure 1 shows how they arrived at their patient population. So they started off with almost 31,000 patients who went through UW and died from 2010 to 2017 with one of those chronic life-limiting illnesses that I mentioned. They excluded almost more than half of them because they were not actually hospitalized within the last 6 months of their life. So that left us with 14,000 patients. However, 11,000 of them actually didn't even have a post documented in their chart. So they were also excluded from the study, leaving us with approximately 3,200 patients. And then of these, almost 1,400 patients were excluded because they actually completed their first post at their last admission and not before. So that left us with a total of 1,818 patients, a third of which wanted full treatment or had full treatment documented, and the remainder had some kind of treatment limiting orders. Table 1 describes the patient population in more detail. So in the first column, we have all patients. And then here in the next 3 columns, we have them divided up by what was documented in their post. So overall, the age was fairly equal amongst the 3 groups. It was a more elderly population represented in this study with a mean age of 70s. There was a slight predominant male representation in the study, 60 to 40%. The study included mostly white populations, but there was also a representation from Black and Asian as well, approximately 10%, and very little representation from other groups and from those with Hispanic ethnicity. In looking at what factors could affect whether patients received discordant care or not, they looked at education, and there was a fairly good representation from a spectrum of patients who had either less than high school education, high school or general, some college or bachelor's and more. Table 1 continued. So looking at whether patients had, there was good representation from patients who had only 1 chronic limiting life illness versus 2 versus 3 versus 4. The spread was fairly equal. And then when they were looking specifically at what kind of chronic life-limiting illnesses patients had, there was very good representation from patients with congestive heart failure, coronary artery disease, cancer, chronic lung disease, and chronic kidney disease, and less representation from those with chronic liver disease, for example. And the last part of Table 1, they wanted to see if the actual characteristics of the post form could affect whether a patient received discordant care or not. So actually, I forgot to mention this earlier. So their form requires the patient or the substitute decision maker to actually sign the form themselves, which is also different from what we have here. So they found that 60% of the patients signed their own form. A smaller proportion of patients had a substitute decision maker to sign it. And there was a small minority of patients where they couldn't really even tell who signed it. They looked at when the post was completed compared to when they were admitted, and that determining that length of time. And on average, patients had a post completed 3 to 4 months before they were hospitalized for their last admission. But the range was quite wide. Some patients had it only a month before, and some patients had their post completed almost a year out from when they were last hospitalized. And lastly, they looked at the admission diagnosis that the patient had going into the hospital. And there was a minority of patients who were admitted for traumatic injuries. So Table 2 is kind of the meat of their results in terms of descriptive statistics. So again, we have our 3 columns, depending on what the patients had documented on their post. And I'll bring your attention to the first 2, comfort measures or limited additional interventions. They found that 31% of patients who had comfort measures only documented still were admitted to the ICU, and that 46% of patients who had limited additional interventions documented were admitted to the ICU. And that being said, 2 of these patients were admitted because they needed symptom management only, whereas in this group, 31 patients, or 4% of patients, who wanted limited additional interventions went for non-invasive ventilation. The authors felt that this was still acceptable and kind of within the scope of the order, so they took them out. And so I bring your attention here to this last row, post-discordant intensive care. They adjusted their numbers, 30% for comfort measures, 41% for limited interventional uh, uh, efforts, for a combined total of 38% of patients in the study received some kind of post-discordant intensive care. They did specify exactly what patients received in the intensive care setting as well. So you can see here, for example, under the comfort measures only column, that 9% of patients receive ventilation, 8% of patients receive vasopressors, and 1% of patients in this group receive CPR. So there's definitely some element of discordant care happening here with respect to what is documented in the post, at least. And the frequency of these interventions that patients in these two groups received was different from those in the full treatment group. And this would make sense. We would expect patients in the full treatment group to receive these interventions as is within their goals, whereas these patients did not. When they did a statistical analysis to determine if there was a true risk reduction, depending on what was documented in the post, they found that there were statistically significant differences. So patients who had limited interventions documented or comfort measures documented, they had a reduced risk or of favoring less intensive care measurement interventions being done. And this was consistent with whether you looked at admission to ICU only or actually receiving life-sustaining treatments. When the authors looked to see, what factors could affect or increase or decrease the risk of receiving discordant care, they found for patients who had documented comfort measures only that if they had cancer with poor prognosis or dementia, they were less likely to actually receive discordant care, meaning what actually happened was more likely to reflect what was documented in the post. Whereas if patients were admitted for trauma, they were more likely to receive discordant care. They were more likely to receive some kind of ICU intervention, which was discordant with what was documented in the post. Some of these findings were carried over to those who had limited interventions documented, for example, those with cancer and those with trauma, but the signal is lost for those with dementia, interestingly. Since this study looked at patients who died from 2010 to 2017, the authors were interested to see if the level of discordant care, or the rate of discordant care, changed over time. But they found that this was actually not the case. So they couldn't describe, or ascribe rather, the rate of discordant care with unfamiliarity with the post form. So the conclusions that they drew from this study were that patients with posts documenting full treatment were significantly more likely to be admitted to the ICU and receive life-sustaining treatment than those with limited intervention orders documented, which is what we would expect and what we would want. However, there was still a proportion of patients who had limited interventions documented that still received ICU care. 38% were admitted and 18% received some kind of life-sustaining treatment. This was more likely to happen in cases where patients were admitted for trauma and less likely to happen when patients had a history of cancer with poor prognosis or dementia. It was not as affected by their age, their race, ethnicity, education, the time that they signed their post, whether it was close to their mission or further away, or whether the post was signed by themselves or their substitute decision maker. And lastly, that the discordance rates have not really changed throughout the years. Now, of course, when we look at those conclusions and we think about how they could apply to ourselves in our own practice, we have to keep in mind the limitations of the study. First and foremost, the study was done in the United States in a single center, so you always have to think about whether that translates to your own practice. But here, their patient population, I think, is very important to look at. So they did not include those who did not get hospitalized within the last 6 months of life. So if you remember from table 1, they actually excluded more than 16,000 patients because they didn't end up going to the hospital. So what might end up happening is that the rate of discordant intensive care may be overestimated or inflated, because a lot of patients who had, say, comfort care only documented may have actually passed at home without receiving intensive care. So we would not capture those patients. This population also did not capture patients who did end up getting intensive care, but out of UW. So if they received it at a different hospital, if EMS started giving CPR, for example, we didn't capture that. So we may have underestimated the rate of discordant care here. This population also does not include those who survive their critical illness. It only includes those who are deceased. So patients may have had comfort care documented only, went to ICU, and survived their acute episode. So they would not be included in their study. So the discordant care rate may actually be underestimated if we miss these patients. And lastly, I think this entire time I've been talking about discordant care, we assume that it's bad, it's not appropriate. But I think it's important to realize, as Anthony said, that patients' goals and wishes can change at any point in time, and the post is just a documentation at one point in time. So I think it's just a tool that we clinicians should use to help guide care. But still, at the time where the decision needs to be made about intensive care measures, it should still be a clinical judgment. So ultimately, discordant care may not necessarily mean inappropriate care in that case. The example here would be in traumatic cases. So with that being said, this is an American study. So I'll pass it over to Tammy to talk about more from a Canadian perspective.
Thanks, Victor. So as Victor said, I'm going to move back to a more Canadian and Ontario perspective into preferences here in Canada for patients and the rules that govern how we practice. So the first thing I wanted to cover is a survey that was done a few years ago regarding Canadians' opinions about advanced care planning. It was an online opinion poll that was administered across the country and essentially asked questions about people's knowledge and plans around advanced care planning. Next slide. So this table delineates their sample population, and you can see that they've got a relatively equal distribution of respondents who are male and female. They also had, interestingly, a good range of age from as young as 18 to more elderly patients. They also had a range of education levels from people with less than a high school education up to university graduates. They covered a broad range of household incomes up to over 150,000 per year. They did cover the entire country, although they had, the study was based in BC. And a good proportion of people who had children in their household. Where they maybe fell a little bit short was they only had 11% of their respondents identified as people who had not been born in Canada, which is much lower than we know those people make up about 20% of the Canadian population. So that is probably a bit of an issue. Next slide. They asked the participants 5 questions, particularly whether they knew what the term advanced care planning meant, which only about 16% of people did. And they asked whether people had had advanced care planning discussions with their family and friends. And even though most people didn't know the term advanced care planning, more than half of people had had a discussion with family or friends at some point about their advanced care plan, as Anthony alluded to earlier. Only about 10% of people had had a discussion with their healthcare professional. So for some reason, more than half of these people are talking to their families and friends about their advanced care plan, but there's a huge discrepancy between that group and those that are discussing it with us in the clinical setting. Only about 20% of people had an advanced care plan that was written down, and about half of people had identified a substitute decision maker. Next slide. There were some factors that were more positively associated with having engaged in advanced care planning. Not surprisingly, older age was more correlated with having a formal advanced care plan. Being female, higher levels of education, and higher income, those groups tended to have an advanced care plan. But interestingly, the authors noted that the last 2 groups, the people with the higher levels of education and higher income, were for some reason less likely to have discussed it with their healthcare provider than people from the other groups within those categories. Next slide. I wanted to touch a little bit on what advanced care planning involves in Ontario, and Anthony kind of introduced this concept. And really there are two main components. The first being the identification of the substitute decision maker, and that can be done through the hierarchy, which we're all familiar with, that's been established in Ontario and which I've included in the slide here, or through the establishment of a power of attorney for personal care. So in my experience, for the most part, I think people go with the hierarchy and have either their spouse or children as their substitute decision maker. But some people do have a documented power of attorney for personal care. And one thing to note is that this is different than a power of attorney for property. So it's important to, when somebody identifies as a power of attorney for a patient, it's important to see the documentation and ensure that they're actually their power of attorney for personal care and not for property. The second component is an advance directive. And it's a bit confusing because advance directives technically don't need to be written down. They can be communicated verbally to the substitute decision maker. If they are written down, they don't actually require a specific form or format. But once those wishes have been communicated to the substitute decision maker, and the language to this is included at the bottom of the slide, those wishes are legally binding on the substitute decision maker, unless at the time that the decision is being made, for whatever reason, the wishes are impossible to carry out. And I'll come back to this later, but I do think it's important that we start encouraging our patients to have a written advance directive rather than simply verbal communication on this topic. Next slide. One thing I wanted to cover as well is this do not resuscitate confirmation form. So this is a form that we see often coming in with patients who have gone to the effort to document their do not resuscitate status. This form requires a family doctor's signature. And next slide, actually. The purpose of the form, can you go back? The purpose of the form is actually not to dictate the care administered by physicians. It's actually in place to direct the practice of paramedics and firefighters. And I have seen on occasion in practice this form implemented as essentially a substitute for a goals of care discussion when a patient comes to hospital, or used in this situation where a patient is not capable of engaging in discussion about their goals of care. And people will see this form and assume that this can act as an A&D, the equivalent of an A&D on a post. But actually, I've spoken to both the CPSO and the CMPA about this form, and that is actually not the case. So while I said on the previous slide that an advance directive doesn't require a specific form and doesn't need to be in a specific format, this actually, though, cannot be used as an advance directive. So what the CMPA told me is that when patients come in with these forms, certainly it indicates a previously expressed wish. However, it should not be used as a substitute for a goals of care discussion. As physicians, we cannot just use this form to document a patient as A&D. We do still need to have the conversation. And what it can be used for is essentially what they recommended, starting point for discussion. So to say, I see that you have this form, or to a substitute decision maker, I see that your loved one has this form. I'd like to talk about their goals of care going forward now that they've come to the hospital. Next slide. I wanted to cover two separate important cases that dictate our actions with respect to withholding and withdrawing life-sustaining treatment. This is the first one is dictating physician actions around withholding life-sustaining treatment. Many of you may be familiar with this case. It's a very recent decision by the Ontario Superior Court of Justice in 2019, and the case was Wozniak versus Livingstone. It was a case that happened at Sunnybrook, actually, as is the case that I'll talk about with withdrawal. And Wozniak was the daughter of a patient who was admitted at Sunnybrook, who had multiple medical comorbidities, had recently had an amputation, had previously been actually documented as being A&D with respect to goals of care, but according to his daughter, had had a change of heart in the previous weeks and wished to be documented as full code. So he was admitted to Sunnybrook, and his code status was documented as full code. However, his medical condition started to decline significantly, and Livingstone and the other physician who were caring for the patient tried to contact the patient's daughter, who was a substitute decision maker, and were not able to reach her for whatever reason. So they made a decision to change the patient's goals of care to do not resuscitate. And one physician put in the order and the other physician co-signed the order. The patient continued to decline. Eventually they were able to reach the daughter, Mrs. Wozniak, who presented to hospital essentially as her father was actively passing. And actually, in the articles I read about this case, there's some suggestion that she herself, she was a nurse, that she herself engaged in CPR at the bedside to try to revive her father. And so she made the decision to pursue these two physicians because her argument was that they did not have the right to change her father's code status in the chart without speaking to her first. And that ultimately that decision was up to her and that his full code status should have been honored. So the case was heard by the Ontario Superior Court of Justice, and ultimately they sided with the two physicians. And what they decided was that physicians do not require consent to withhold CPR that is deemed to be medically inappropriate. Confusingly somewhat, they've said that physicians need to distinguish between scenarios where CPR is outside the standard of care and should not be offered, which they said was the case based on their understanding of the case that was presented here. We need to distinguish between that and cases where CPR is still within the standard of care, but physicians do not feel that it's in the patient's best interests, and that these two types of scenarios require a different response on our end. And actually we discussed this as a group and we had some trouble coming up with an example of option 2, basically, which maybe we can discuss after the talk. And importantly, they also said we have a responsibility to communicate with family and patients. So it's not, this decision doesn't give us the right to unilaterally change code status in a patient's chart without discussing it with them. And certainly it sounds like these physicians did try to reach Mrs. Wozniak, but importantly, these need to be open discussions with family and patients. Next slide. The next case I wanted to cover, I think most people will be familiar with. This also occurred at Sunnybrook in 2013. And the case is Cuthbertson versus Rizzulli. And this one actually was heard by the Supreme Court of Canada. So the story behind this is Mr. Rizzulli had a meningioma, which he had resected at Sunnybrook. Unfortunately, he developed bacterial meningitis as a complication and had a bad outcome, ended up in the ICU, intubated with very poor function and a poor prognosis for recovery with essentially limited cognitive capacity. So the ICU physician, who is Cuthbertson, and I believe there was a second physician as well, told the family that they felt that the life-sustaining treatment that had been started was unlikely to result in Mr. Rizzulli having a positive outcome, and that they planned to withdraw life-sustaining treatment unless the family applied for an injunction to prevent them. The family ultimately did do this, and the case went all the way to the Supreme Court of Canada. However, the decision, which was that withdrawal of treatment requires consent from the substitute decision maker, only applies in Ontario because it was based on the Healthcare Consent Act, which is a piece of legislation in Ontario. So in this case, the Supreme Court said, once a treatment has been instituted, withdrawal of that treatment requires the consent of the patient or the substitute decision maker. And importantly, if the substitute decision maker does not consent to withdrawal of care, and the physician feels strongly that the SDM is not adhering to the principles that are in keeping with the role of the SDM, rather than going to the courts, they should apply to Ontario's Consent and Capacity Board to assess the situation. Next slide. You may be familiar with the Consent and Capacity Board. It's an Ontario-based institution that reviews, at least in their last review, over 8,000 applications. Most of what they review is involuntary admissions, capacities to make treatment decisions, and community treatment orders. So I think our psychiatry colleagues are quite familiar with dealing with the Consent and Capacity Board. Interestingly, they actually will hear cases very quickly. They will hear a case typically within 1 week, and they make their decision within 1 day. Only a very small percentage of what they review, and it's the second to last category here at the bottom, the orange piece, which is the smallest, are cases that deal with compliance with the principles of substitute decision-making. And the data on those types of cases are a little bit old, but as of 2013, they had heard, I think it's 30 cases, and sided with physicians in 23 of those cases. If the SDM or the patient does not agree with the decision of the Consent and Capacity Board, they can appeal to the Ontario Superior Court of Justice. In the compliance with SDM decision-making cases, of those there were 11 appeals, and only one of those was actually overturned by the Ontario Superior Court of Justice. So it seems like for the most part, the CCB is siding with physicians, and the Ontario Superior Court of Justice is holding up the decisions of the CCB. The main advantage of using the CCB is that the turnaround time is much faster. So rather than going to the courts where you're certainly signing up for probably several months worth of presenting to court and having the case heard, the CCB's goal is to turn around these cases quickly. Next slide. The key points from our presentation today, and we'd be happy to take questions and discussion, are that disclosure of treatment outcomes and their likelihood is important when talking to patients about their goals of care at the end of life. Treatment limiting orders for life-sustaining treatment are associated with lower rates of ICU admission, but we know from all the data that were presented today that a certain percentage of patients are still getting discordant care. We also know that patients are talking with their families and friends about advanced care planning, but for whatever reason, a much smaller percentage of them are talking to us. And certainly an admission where a patient is quite sick is maybe not the best time to bring it up, but in the outpatient setting, it would certainly be appropriate. Or, if the patient is recovering and preparing for discharge, I don't think it would be unreasonable to plant the seed about this conversation and make sure the patient and their family are thinking about it. And finally, we think it's important to encourage patients to engage in advanced care planning, specifically through identifying a substitute decision maker, whether that includes a power of attorney for personal care or whether they identify their SDM through the hierarchy, and to document their advanced care plan in writing to ensure that their wishes are respected if they're admitted to hospital and they're not able to advocate for themselves. And thank you. So we're happy to take any questions.
Terrific. Thank you very much, guys. Very nice review. So I'll encourage people to submit their questions through the Q&A button at the bottom. I don't know if I can allow the mic to go live, but I'll try. So Dr. Satya has been vigorously typing 3 questions. So we'll let him have 1 and then see if there are other questions after that. So Imran, are you able to make your mic go live? Doesn't look like it, so we can't hear him. So I'm gonna take your first question, and we'll go from there. So decision making is much broader than physician and patient. Because we live in a world with limited resources, beds, money are scarce. Hence, unnecessary use of resources reduce the quality of life for all. Any thoughts or comments?
I can
Tough
comment.
question.
Yeah, I can comment. It's a really good question. And I think it maybe alludes to a concept of, the greater health for all maybe outweighs the greater health of one, which is, I think, challenging for a physician or healthcare provider to grasp or to honor. From what I've seen in real world context, having worked in our healthcare system for the last few years, I think that even though there's resource and bed availability issues, if a patient has ever voiced a preference for goals of care and those had to be enacted, we've always made accommodation and made resources available for that patient. So I feel that, regardless of what I felt the overall resource constraints or availability are or is, that, I would still honor a patient's wishes for goals of care and whatever that would be. But I think this question would be probably variable depending on who you ask.
I also think it's a bit of a challenge in the sense, as Anthony was saying, when you're having a discussion with one patient or one family, you may be thinking about this in the back of your mind, whether the goals of care and the care that you're giving are an appropriate use of resources. But certainly I've never felt comfortable making that argument to a patient or a family. And I'm not sure if anyone has a way that they can say that they feel is appropriate and that a family or a patient has responded well to. But I would be worried of the response.
Yeah, pretty tough, In the middle of a difficult conversation to not focus directly on the patient in front of you. I agree. I'll do Imran's second question, but maybe I'll just get your thoughts. And one of the things that has struck me, having been to the CCB a few times now on behalf of the hospital, is the difficulty teasing out from the SDM their own versus the patient's wishes, and trying to explicitly ask them what the patient would want and whether they're actually able to take that and take a step back instead of the stress and fear of the moment. Any thoughts?
I agree completely. And I think there's two factors there. I think sometimes someone ends up in a situation where they're the SDM and they just frankly weren't prepared because no discussion was had. And so they're not sure what the wishes were. And so they end up sort of defaulting to what their preferences and values would be if they're really genuinely not sure what the person would have wanted, versus situations where, and an example would be where a patient comes in with a DNRC form. And so you're pretty sure that patient, didn't want to be full code, and yet the SDM is saying that they are. And so you're relatively certain there's a frank discordance between what the SDM is expressing and what the patient wants. I have been to a CCB hearing, but not for this. But just from my personal experience, it is quite challenging to do this in any conversation, not just in the CCB. And I think that's why I made the point a few times that I really think these things should be in writing. Because, if you just didn't have the discussion and you're trying your best, but you're just not sure, that's sort of one thing. But when you get into these cases where it just doesn't seem like there's a concordance between what the two parties are asking for, I think having these things in writing and encouraging our patients to have them in writing would probably protect patients from a lot of unnecessary intervention.
Terrific. Okay, I'm going to go ahead with Dr. Satya's second question. It's as much a comment as a question. It'd be interesting to have a discussion on our duty to prolong quality of life when you can reduce suffering and when you cannot sustain life. He would like to hear your thoughts on what you consider the bedrock of quality of life. These are tough questions, Dr. Satya. And what you consider suffering to be. And if you don't want to try and take that on in full, I will understand. Anybody?
I can comment. I think suffering and quality of life are very, very subjective principles. And maybe that goes back to some of the cognitive pieces that we highlighted that go into decision-making around end of life. I don't think I could give you a uniform answer because they would be my personal views, much like, I think if you asked a patient, 10 patients would all have 10 different views on what they consider to be suffering. I think things that have helped us and what we've learned in some goals in care workshops over our training is, where patients envision them in 5 years, or, what things are most important to them, what is the most disabling symptom they have, to try to tease those principles out when exploring decision making.
Thank you. I have a comment from Dr. Dorasamy. He's saying, I would strongly advise we discuss quality of dying when advising about end-of-life care issues rather than focus on quality of life, since many of these patients already have a dismal quality of life. And then he reported, or referenced an article from JAMA. Thoughts?
I think, no, that's a very good point, actually. And I agree with what Anthony said earlier. It's very subjective. I think, in my short time being a resident so far and seeing what we do in the healthcare setting, we don't talk as much about the process of dying with patients very much. I can understand why, it's not necessarily the most pleasant and comfortable topic to talk about, and it's difficult to gauge, who is ready for that conversation and who isn't. But that's not, I agree with Dr. Dorasamy that that's not a reason to not discuss it, right? It's just as important to talk about what the dying process would look like for patients who have a foreseeable decline in the near future. And that would help them make their decisions too about their goals around end-of-life care. I just wanted to get your,
go ahead, guys.
I just wanted to comment on number one as well about the question about resources and reduced quality of life for other patients. I think for sure if there's, that's the whole premise behind one of the papers about, reducing discordant care, because it's a loss-loss situation. You're not helping the patient, relieve suffering or improve their quality of life, and you're spending resources to do that. So I think there's obviously an impetus to reduce discordant care, and I think focus on improving quality of life for patients. But I also think we need to acknowledge that as healthcare providers, we're also a resource, we're a human resource. And by having, an increased number of discordant care cases, that puts a burden on us too. We talk about physician wellness and burnout. And I think by doing extra procedures, work that really does not result in any meaningful benefit, that's a waste of resources too.
Thank you, Victor. Okay, folks, I'm going to wrap it up. I'm embarrassed to tell you that I don't have a code, and I thought we had gone away from a code. Were you guys given anything to show for the CME?
No.
Okay, so I apologize. I know that we did change the process through Dr. Crowther's office, but I have lost track of that. So if you guys, anybody who would like to follow up, please email me or my office, Annetta Gianomo, and we'll sort that out for you. And once again, my apologies. And I want to congratulate our speakers for an excellent round. And I always really enjoy our Chief Residence rounds. And nice work, guys.
Thank you.